I'll go ahead and introduce myself. My name is Dr. Andres Fonseca. I'm a consultant psychiatrist by background, but I'm also the CEO and one of the founders of Thrive. Yeah, today we are. This is Mental Health Awareness Week, and we're talking about the topic that is the focus of the Mental Health Awareness Week, which is anxiety. And I think a lot of people would have heard of anxiety. So the purpose of the seminar today is to try and perhaps myth bust a little bit, and also talk about what is and what isn't anxiety. We can use the term quite loosely sometimes, and it's about sort of refining our knowledge of that and understanding, for example, the way somebody like me, who's a mental health professional, might see it, and how that differs from what somebody else, somebody talking casually, might see it, and where those two things marry or overlap, and just to try and get a better idea of how to think about it. And I thought a good place to start would be to just look at this thing here, which is going to look very busy and confusing. So just bear with me. So this is I just took this from the ICD-10, the ICD-11 website. So this is the World Health Organization publishes a manual called the International Classification of Disease, and they are on version 11 now. And basically, they have coded all conditions in this kind of hierarchical way, and they give descriptions of each, and these descriptions are the ones used to guide somebody like me to come to a diagnosis of a condition, if that makes sense, right? So this is like the gold standard of what we look for when we're trying to sort of make up our minds as to whether there is an anxiety disorder or not present. So I thought it would be a good way to start to sort of reveal this to you and just try to sort of see what it says, see what, like, the kind of thing that it kind of expresses, and how it's thought about. There's another system of classification that is also very commonly used. The definition is slightly different, and it's called the DSM. You might have heard this term before. The DSM, this is the American version of this classification of disease. Is a statistical manual that basically describes the frequency in which some of these symptoms present together, and from that it kind of arises at this classification of disease as well. So DSM is widely used throughout the world, but is something that was developed in the States, and the statistics that they refer to is mostly gathered from the States. And the ICD-11 is a system that is developed, supposed to be more international, because it's developed by the World Health Organization. So here we have the definition. So anxiety and fear-related disorders are characterized by excessive fear and anxiety. So one interesting thing it makes at the very beginning is that it differentiates between fear and anxiety. And then obviously it talks about related behavioral disturbances and the symptoms. They have to be important or impactful enough to result in significant distress or significant impairment in personal, family, social, educational, or other important areas of functioning. So so basically telling us two things: is you have to have this excessive fear and anxiety, and then you have to have these changes in your behavior, and they have to be severe enough to result in significant distress or impairment. It doesn't need to have both, right? So it's or impairment. So it's one is enough, really. And if you read further, it says that fear and anxiety are closely related phenomena. So it defines fear as something that represents a reaction to a perceived imminent threat in the present. So you perceive, and there's an important key word there, which is perceived imminent threat. So the threat may or may not be, it has to be perceived, is kind of the key point. But it may be, it doesn't tell you specific situations, if you can see there. It just doesn't say this is the thing that is likely to result in fear. No, it's a perceived situation. It's a perceived imminent threat. Is the bottom line? Is the thing that is important to trigger fear. And anxiety is more future-oriented. Anxiety is more about anticipation. So it's a perceived anticipated threat. So it's not present in the moment. It's something that may or may not occur in the future. So the fear and anxiety disorders, the focus is the apprehension to the situation that it triggers, that triggers the fear of anxiety. And one important thing to also be also understand about anxiety disorders is that that apprehension that is talking about there results in avoidance, right? Results in avoidance. So that's actually one important feature. So I think just to summarize what we've learned so far is that there is fear or anxiety. Fear is more immediate. There's an immediate perceived threat. Anxiety is more, we anticipate that there will be a threat in the future. And to be classified as an anxiety disorder, there has to be significant distress or significant dysfunction. And there has to be this apprehension. And I'm going to add something here that is not stated in the definition, which is very frequently accompanied by some form of avoidance. Avoidance is very important. Okay. Oh, let me see if I can do that very quickly. Sorry, I'll just stop that because I'm just trying to present with you with a question. So I'm just going to do that now, and you can join in. Right, there we go. So this is more, we've been talking a little bit about it. It's more about just tell me what you think are the most common. So you can join the Slido, you can present, you can use the QR code or something, and we will be using this throughout the presentation to just get a feel for your understanding of what we've been saying, what's going on. But just sort of tell me what you think are, what you feel are the more common characteristics of all anxiety disorders. So panic attacks. It's interesting. The panic attacks are featured so prominently at the moment. We'll talk about that. We'll talk about panic attacks specifically in a minute. So we've got worry as a big one. Stress. So stress is a very generic term. It does appear very frequently when we discuss anxiety, but stress doesn't have a specific clinical definition, which is interesting, even though it comes up so frequently. Different to anxiety. Anxiety, you saw that it's got this structured definition. It looks about anticipatory anxiety and fear. So fear is there. So is both there. Feeling overwhelmed. And then we see a lot of symptoms that may occur in anxiety. So having chest pains, for example, palpitations, having a racing heart, which is the same thing, physical symptoms. But yeah, so the central response that we have is that worry. Avoidance is very important. So I would say, as we saw in the previous slide, I would say it's going to be worry, it's going to be anticipation of something happening, or it's going to be fear, or something that we're perceiving in the moment. And also we're going to sort of very frequently have avoidance, and then it may come accompanied by all those symptoms that you're describing there. Now we've got other things like, for example, I saw in a minute catastrophizing. So that would be a more psychological symptom, which is we are anticipating the worst to happen, unable to focus on that. That's very common. We saw in the earlier stages, which is that distress plus that inability to function, either or. But we say you've got depression there, and you've got, I saw earlier, also hopelessness. Those are not typical symptoms of anxiety. Those are more typical symptoms of depression. Interestingly, obviously, they can happen together, and very commonly they are what I'm going to call comorbid. We'll see that in a minute later on. But I think that gives us a very good idea for what are the common characteristics. This worry, this fear, plus the physical symptoms, plus the distress and dysfunction. I think that's a good working definition for us to understand it. Yeah. So let me see if this can move on. So this is about the lifetime risk. So how frequent do we think these conditions are, right? So I've given you a few choices there for you to sort of think about. And you can see that my lowest one is quite high. It's 15%. 15% is a lot. But what do you expect the lifetime risk is? So lifetime risk means how likely are we to encounter a person that has had anxiety? So if we ask a person that is 75 years old, for example, how likely are they to tell us that at any point in their life they had anxiety? And anxiety, defined as we saw before, they have either fear or anticipatory anxiety, that worry that we were talking about, and it's caused either significant distress or significant dysfunction, as per the definition that we saw earlier. And we probably had some avoidance, right? And people thinking 35%. And actually, you're pretty much right. It's interesting because when we talk about mental health conditions in general, right, people say it's about 1 in 4, 1 in 4. But if you look at the whole distribution of all mental health conditions, is probably more than 1 in 4, because we see as any anxiety disorder at any point in life is around the 30-35% mark, as you've indicated there. So you're correct. They are very, very frequent, indeed. And you know, so about 1/3 of us will experience significant distress or dysfunction as a result of anxiety or fear at some point in our lives. So absolutely. When do you think they commonly start? I think it's another question for you to sort of think about. So we know that by age 75, we know that about 30-35% of people are going to have experienced one of these, right? And what do you think they're likely to start? So most people feel that these are common conditions that can start with people as teenagers. And again, that's winning the poll by a lot. And again, I would say that you are correct. The other people that are saying when people are young adults and when people are middle-aged, they're also kind of correct, because we're going to see a distribution on the next slide of how these things present over time. So if you look at the distribution of the different, so this is the thing that perhaps we talked about anxiety disorders in general at the beginning and what the common characteristics are. And you've answered what you think are very, very pervasive features of all anxiety disorders. Yeah, so we'll explore those. But now we're going to sort of break it down into different kinds of anxiety disorder that we may encounter. And the interesting thing there is that they can present, or they do present, at different points in life, right? So you said when people are teenagers, and I will tell you that 50% of all anxiety disorders, 50%, start before the age of 11. That's kind of the age when about 50% of all anxiety disorders have already presented, okay? But if we look at different anxiety disorders, they present at different times in life, right? So I've got a few there for you that we'll go through briefly. So got separation anxiety, very, very frequent, as you can see, in children. And the age at when it happens is also relevant. It's around the age of 5, 6. So it's when children are starting to go to school, and that separation anxiety is when it kicks in, right? So it's when you're worried, you fear your mother or your parent leaving you behind. And that is the fear that can be quite pervasive and quite distressing, and actually can result in school refusal, and can be a focus area of treatment even at that stage. Because okay, in a child there will be, so a lot of children don't like going to school, a lot of children love going to school, but some children struggle, and okay, they adapt, and that's fine. But we're talking about the children that have significant distress, and their function is affected, so they're not even able to learn or progress at school. Those are the ones that we would call they have diagnosable, quote unquote, separation anxiety. And then we also have simple phobias at the same age. All right. So that is what is a simple phobia? A simple phobia is a fear. This is one that is fear. So anxiety, anticipating a situation that is going to happen in the future. Fear, more there's a stimulus, there's something that we perceive, that we see as threatening. So simple phobias are, for example, arachnophobia, fear of spiders. That would be an example of a simple phobia. And again, a lot of us are a little bit worried about or scared of spiders, but they don't impede our function and they don't cause significant distress. So what is the difference? Again, that when function is compromised or when there's significant distress. That's when we see those phobias, and they can be very powerful in that people are avoiding going into sheds, and I mean in that case it's unlikely to cause a function. You know, they may cause significant distress, but they're not going to cause any problems with function. However, it can get as severe as you know, not being able to sort of leave the home, or fear, you know, playing outside, or things like that, for fear of encountering perhaps a spider or a dog or something like that. You know, those are the focuses. So those are very early. They start very early. They can be lifetime, but they start very early. They usually resolve also quickly. And then we've got 10, 11. You've got the you know, social phobia. You see the light green is what I was telling you about the age of 11. That's the average when they always start. But then we have social phobia when people are beginning the prepubescent. That's when that kicks in, and it's a fear. If you think about what the threat is, you know, why are we developing these fears at these particular ages? You can think about the developmental history of the person. So what ensures your survival when you're a kid? Well, you need to have parents that are going to look after you, right? So if you're separated from your parents, that's what's triggering the fear. That can be abnormal, right? So the other fear is fear of simple threats, like, for example, spiders, snakes, and that sort of thing. And we seem as human to be prepared to have those fears specifically. So children don't tend to have a fear of bleach bottles or cars, which are a lot more dangerous to them than spiders or snakes. The fear that we come pre-prepared to acquire is those kinds of creatures. And again, it's when we're very young that those fears are most relevant, and that's why they kind of start at those ages. You know, that could threaten the kid's life. So yeah, most people are a little bit scared of those things, and some people are very scared of those things. It becomes excessive. Anxiety disorders, you know, become a thing. So then is social anxiety. Why social anxiety? Why prepubescent? So you're trying to get accepted by your peers. So that's going to be very important for what kind of links you form with others in your life, right? So if you imagine life 100, 200,000 years ago, you know, before we had civilization, being accepted as part of a tribe was very, very important. Actually, your survival depended on it. So there's that critical time when if that doesn't happen, if we get rejected, if we're not accepted, we could be in danger. And that's where that, you know, evolutionary, you might argue, again, we don't know this for sure, but it might be because that is the crisis, that is the thing that comes up during that time. And that's why it's more likely to sort of start during that time when we might be rejected by the group. Then we have agoraphobia and OCD more in the 20s as a young adult. So agoraphobia is more of a fear. Agoraphobia is poorly understood, I think, in general, because people explain it as a fear of open spaces. Not really. The fear that is at the bottom of agoraphobia is a fear of being trapped in some way, not being able to escape a situation, right? So the threat tends to be, I am going to be in a position where I cannot escape. And when you ask about people sort of what is the fear, what is it they're worried about, they tend to tell you is you know, that I'm not going to be able to get help. That's a very common fear. So I'm going to be trapped, and I'm even though people are going to try to help me, it's not going to happen. It just can't happen. So I'm not going to be able to sort of you know, be evacuated if something happens. If I have a heart attack, I'm not going to be able to be taken somewhere safe. That's one situation. Or fear of losing my mind is the other one that people tend to sort of say. Losing control is the other fear that they tend to sort of discuss. So we've come across, you know, we've managed those early, more concrete threats, and now it's more about a generic threat, about being trapped, not being able to resolve a situation, being you know, being constrained in some way. That's the agoraphobia. So agoraphobia can happen in public transport because we cannot leave, in a train because again you cannot leave, can happen in a busy shopping area, if you go to a concert. That's when those fears tend to kick in. And agora means market, is the fear of the marketplace. Why does it also happen when you're in the middle of nowhere? Because again, that might be perceived as an inescapable situation. Nobody's going to find me. I'm not going to be able to find help. I'm not going to be able to get to like a hospital in time if I'm in the middle of nowhere with nothing, no communication, nothing. So that's why it can also be sort of in very open spaces. So people sort of, if it's inescapable, what does it happen when it's very open spaces? It's because of that. It's because people fear that they might not be able to seek or find help or find refuge in time. So we have OCD. OCD is interesting because it's not really, I mean, it does have a lot of commonalities with anxiety disorders, but not really an anxiety disorder. It's a bit special. So it's obsessive compulsive disorder. And the fear is that you've got these obsessive ruminations and you've got some compulsive compulsions. If you don't do the compulsions, you end up feeling anxious. But it's a different kind of I would usually tend to sort of list it here, but I'm not going to talk about it in detail because it's a different kind of thing. We've got PTSD, post-traumatic stress disorder. Again, tends to be classified with the fear disorders, and is more specific to a situation where we were traumatized. So, we were victims of trauma of some kind, and then we sensitized to that type of situation and stimulus. Okay, and why is the onset a bit later? Is because again, it can happen very early, and if it happens very early, if you're exposed to trauma very early, it doesn't tend to manifest itself exactly as PTSD. It tends to manifest itself as something else called a personality disorder because your development is disrupted in a very significant way. So when it's PTSD, it's happened later, and you had some coping mechanisms, but they've been overwhelmed. But your personality is not, your development has not been compromised. So that's kind of why it presents a bit later. And then interestingly, a lot of people were saying panic attacks, panic disorders, that comes later. And you can see age 24, 25, that's when those kinds of conditions happen. And then even later in life is this more generalized fear, which doesn't have a particular focus. It's a more abstract fear, more beyond, things could happen that I can anticipate will go wrong, but it's nothing specific. That's more the generalized anxiety disorder presentation, which happens a lot later in life. It's a bit vaguer. And a bit harder to pin down. So out of all of these, I want you to think about which one do you think is the most frequent. Maybe it's because you've heard about it more frequently. What is your immediate reaction to all of these? The way I've explained them as well. So social phobia, agoraphobia, that fear of being trapped in different situations, could be in the outside, could be in a marketplace or something like that. It could be in a busy area, or it could be in the outside. And then this vague generalized anxiety disorder doesn't have a specific worry. It has multiple worries, and they changes from one to the other, to the other, to the other. And the symptoms are not, you don't get panic attacks really, but you get this constant fear. So some of those very powerful physical symptoms that we were talking about at the beginning when you were answering my question in the Slido, they don't tend to happen, or if they happen, they are low grade or constant. Rather than an explosion, a panic attack, which comes with all of those very, very significant bodily symptoms that you put in the slide. And then panic disorder, which is characterized by these repeated panic attacks. Sometimes the person doesn't even know why they're happening. So there we go. I think you've had time to sort of form your own ideas. So I'll tell you what the percentage is. So interestingly, we've got these ones that happen early, that are very frequent at that age. So specific phobia, social phobia, and separation anxiety. They're very, very common in young people, as you've heard, like quite common. And then agoraphobia is about 3 to 4% of the population, and so is generalized anxiety disorder. So the most frequent in the whole list, just to reveal it, is specific phobias. Specific phobias is around 6%, 6-7% of the population, right? Accompanied by those others, but 6-7%. And then you have panic disorder, less frequent, 2 to 3%, and then agoraphobia, 3-4%. and generalized anxiety the same, more or less the same, 3-4%. Now, the fact that you've had one doesn't necessarily mean that it protects you from another. In fact, you're more likely, if you have some anxiety disorders earlier in life, you could go on to develop other anxiety disorders later on in life that are different. So maybe you had specific phobias and you still retain some of those specific phobias, and then as you get older and as you develop, you may develop other presentations of anxiety as well. So that's important to know. I wanted to sort of give you a case for you to think about. And I've got a few cases for you to sort of think about today. And this is about when you're confronted with a situation, what is the best, because it's all well and good to sort of talk about anxiety in the abstract and thinking about how frequent it is and how problematic it might be. But it's also, I think it's also quite useful to think about what we might do if we encounter it in the real world. So here is an example of a presentation, right? So this is a mother of three. She's an architect. She collapses in the tube on her way to work. She can't breathe. She's got a pain in her chest. She's got palpitations. She's got dry mouth. And then OE means on examination. So her pulse is 112. So it's very fast. Normal pulse is, you will know, 60, 70, 80 sometimes. But, resting pulse is going to be about 60 to 80 maximum. More close to the 60 than to the 80. But yeah, so it's 112. Her pupils are big, but they're equal. That might not mean very much to you, but big pupils mean that somebody is either scared or excited. That's what that means, or that they've used stimulants. That's the other possibility for big pupils. And then she's got this high frequency, low amplitude bilateral. So that's a lot of words that mean that she's got a bit of a shake in her hands, which is like that, So her hands are shaking a little bit like that. That's what that means. And is when she's trying to move her hand, it's very shaky, right? So you've encountered this person on the tube. You're trying to assist them. What is it that you should be thinking about doing here? So I've got a few things for you to consider. So when you see a person presenting with any condition, anything that may be affecting them, I think I want you to ask yourself, are they having any symptoms? In this case, you can see here that she's having quite a few symptoms. She feels that she cannot breathe. She's got a pain in her chest. She's got these palpitations. The heart is beating very fast, 112. She's got this dry mouth, and then she's got the shakiness, right? So she's got all those symptoms. Is there distress? So she appears to be distressed. I mean, I didn't say it specifically in the scenario, but obviously you anticipate that she will be. Is there dysfunction? This could be disrupting her day, her work day quite badly. So there's a possibility that there might be dysfunction. You'll have to explore it, but it's very likely given the scenario. Is there a risk? And then you have to think about what is the potential risk. So somebody like her, what might be a risk for her? That doesn't seem to be any immediate risk, anything that she's going to do that is going to put herself in danger or other people in danger. But for example, long term, if this continues to be a problem for her, she could lose her job, or she could be so impeded that she cannot longer get to work. So that might be a risk in itself that we need to sort of think about. So what is the risk if we immediately there's other risks that can happen that are not related to this is an anxiety presentation. A big one would be that this is a heart problem of some sort. We don't know the diagnosis. We have no idea. But she's presenting with chest pain and she's presenting with this high pulse and everything else. So we might be thinking immediately, oh, this might be a panic attack, but we don't know. She doesn't know either. And it could be a million other things. So the risk is that we miss something else because we're assuming it's a particular thing, right? So what should we do? I think it's very important in this case to think about what should we do, because a lot of people might feel, oh, this might be just a panic attack, and we might just be very happy to just comfort her, help her calm down, and that's it, right? I would argue that you do need to call emergency services in this case because you don't really know. So she's got a high pulse. She's telling you that she's having difficulty breathing, and she's got a chest pain, right? So I think it's very important that we do take it seriously, and that we help her get seen by the paramedics, right? And maybe even taken to hospital for a few tests and a few checks. Okay. Now she might feel very embarrassed as well. Then she might think, oh, I shouldn't bother people. I shouldn't trouble people for this because maybe it's a panic attack and maybe I don't need to seek any help. Again, very important that she doesn't, that she does sort of seek help. She can be even made feel bad, but the paramedic says, oh, you're fine, love, it was just a panic attack. And then she feels bad as a result of that, right? And the answer is that she, or the truth is that she didn't know that she was having a panic, and you didn't know, you who were trying to support her, you didn't know that it was a panic attack. You may suspect it. It might be like maybe top of your list, but you don't know. She doesn't know. Nobody knows. Until you do the checks, you don't know. It could be something else. So it's important that she doesn't feel bad, and we don't make her feel bad about seeking this help at this particular point in time, right? I think that's very important. If you take nothing else away, is that yes, a presentation like hers could be all due to a panic attack, and panic attacks are not likely to be harmful, but we could miss. I think the biggest risk that we have here is missing something that could be life-threatening for her, because we assume that it's anxiety, right? So let's not assume. Let's just do the right thing. And again, she shouldn't feel bad, and we shouldn't make her feel bad for seeking help. In fact, we should encourage her to seek help. All right. So, a question for you: what do you think? Anxiety disorders affect more men, more women, the same, both equally? All right. So I'll just let you think about that for a minute and see what the wisdom is. So interestingly, we see that affect more men is the least popular option in the audience, by quite a number, and then affect more women and affect both equally were kind of tied at the beginning, and then at the moment is more popular that affect both equally. That's interesting. All right. Just let you think about it for a few seconds more before I kind of reveal the answer to what you're thinking. All right. I think we'll go on to the next one. Thank you very much for participating and thinking about that. The answer is it depends on the condition, but in general, they tend to be more frequent in women than in men. Now, I think you're right in your bet about saying maybe they affect both equally, but we don't have so reliable numbers for men, because we all know that men are less likely to seek help, right? So that is a valid concern. But we do know that men in general have a more risk-taking. I'm not talking about a specific man. So I'm talking about if you do the average of all men. This is what happens. So there might be men in your life that are very, very risk averse, and there might be women that are very, very tolerating of risk, right? So this is true. However, on average, this is men seem to be less risk averse or more risk prone than women in general, and it kind of speaks to this perceived threat, anticipated threat. So that is characteristic of anxiety disorder. So it seems that by and large, they tend to affect more women than men. And you see that the biggest differences with panic disorders is 2.5 times more frequent in women than it is in men. And the least is social phobia, which is about 1.4 more times. So it's a little bit more likely social phobia in women than in men. Now, any anxiety disorder is around the 1.5 mark. So you were kind of right. So it's not doubly. So it's more, if you look at every anxiety disorder, is a little bit more frequent in men than women, but the difference is not that big, as maybe some people sort of think about. You've got generalized anxiety disorder, there, and then you've got agoraphobia. It's a bit more frequent. It's about 2 times more frequent. And then you've got simple phobias. Again, these tend to start in children, as you say. So interesting, we do see a difference between girls and boys in simple phobias, which is about 2 and a bit times more frequent there. Another case for you to think about. So 18-year-old William has visions of blood. He cannot stand the sight of knives. Isolated at home in his room, refuses to see family and friends, refuses to go out, and has these thoughts, these ruminating thoughts about killing his brother. All right, which sound very distressing. Okay, so this is quite a difficult scenario to encounter. Let's imagine that this is your teenager. Let's imagine that this is somebody that you know. All the cases that I'm talking about are real, by the way. So they are obviously is not the right name or the you know. I've disguised all the actual facts, but they are real cases that I've encountered in my career, right? So this is a real presentation of somebody. So you might think, what is the? So if you think about what I was telling you before, let's think about what are the symptoms? You know, when you're encountering a situation like this, the first thing that may happen to you is like, oh my God, what can I do? What can I do to support somebody, maybe at work, or maybe a friend of yours that tells you these things? You know, what can you do? Seems like a dire situation, very, very difficult. If you go through this simple algorithm of, you know, what are the symptoms? Is there distress? Is there dysfunction? Is there any risk? And what should we do? That might help. You know, that might help you feel more oriented as to how can you sort of be helpful in a case like this, right? So what are the symptoms? We have some symptoms. Has these visions of blood. He's telling you that he cannot stand the sight of knives. That's interesting, all right? Isolates at home in his room, and is not seeing family. He's not going out. So we know that there is distress. I mean, it's very clear that there is distress. So we know that. So we've got symptoms. There is distress. Is there dysfunction? Well, very likely, right? He's not going out. So he's isolating himself in his room even. In fact, his family are having trouble supporting him and bringing food to him in this situation, right? So it's as you know, significant as that. And he's got these very disturbing thoughts that he finds very, very distressing about killing his brother. You know, and that's why he doesn't want to see any members of his family, because he worries about hurting them. That's the biggest worry in his mind. So he doesn't want to see anybody because he's worried about hurting them. Now, this is actually this is a presentation of obsessive compulsive disorder. All right, and maybe it's a presentation that people are not familiar with, but I thought I'll explain it a little bit. Even though obsessive compulsive disorder is not necessarily one of the anxiety disorders, it has a lot of commonalities. So he's got these very active worries, these ruminations, these awful repetitive thoughts that are making him quite distressed and quite anxious, really. So if you look at the symptoms, they are symptoms of anxiety, very similar. And he's got these ruminations. So obviously we need to sort of, what do? We need to make this person safe. They obviously need support, and they need support immediately. These thoughts are worrying. They need to be evaluated, and they need to be evaluated by somebody very quickly. We're in a situation where we're going to call for professional support very quickly, and we might need to call an ambulance even in this case. You know, he's not doing very well, so we'll see what happens there. Or we may need to make sure if he's a little bit better, if he's accepting some support or something, we might be able to sort of wait for a little bit longer and help him get support in a more structured way, get the GP on board, get local mental health services involved. But yeah, it's a case of obsessive compulsive disorders. The obsessive thoughts are these ruminations about you know, harming his family, and the compulsion is about removing himself. The avoidance is avoiding anything and everything that is to do with contacting them for fear. The fear is hurting them in any way, right? Is this person dangerous to others? If it's a presentation of OCD, the answer is no. You know, in fact, when you do the treatment, well, we'll see in a minute, you do something that is called exposure and response prevention. And you do tend to sort of use knives, for example, blunt knives, for him to sort of get more used to it and prevent that immediate response, immediate anxiety forms that manifests itself when he sees a knife or anything like that. That might be done in treatment. But yeah, so it's just for you to understand that there can be very dramatic presentations of anxiety and anxiety-related disorders that may need immediate support, and we shouldn't feel necessarily overwhelmed or scared. It's more about, are we finding these things, and can we, what do we need to do? Call an ambulance, call the GP, sort it out. Yeah. I've got a final one for you. So this is a 15-year-old girl isolating herself in a room, doesn't go to restaurants, supermarkets, or crowded spaces. Her mom has caught her stealing her tablets. Sometimes she can go out accompanied by somebody. She will not go out on her own. And at quiet times, she can venture out on her own, but she will always carry her phone. So that's another presentation, and you might be thinking, what's going on? So again, symptoms. What are the symptoms? She's isolating herself in the room, cannot go into restaurants. She seems to be stealing tablets. We don't know what that is about. She can go out and accompany. She has this safety mechanism with the phone, right? She carries a phone, and that makes her feel a bit better. Okay, so and she needs somebody's company to go out. So on the surface, what is this? We've got the symptoms. We've got the stress. Yes, we've got dysfunction. It's probably not be able to go. If she's isolating herself in a room, she's not going to school. So we definitely have dysfunction. And again, this is a situation where, are there any risks? What are the risks? We don't know what's happening with these tablets. And obviously, the other risk that we can think about is she going to be neglecting herself in any way? Like with William above, he might not be even accepting meals for fear of having contact with his family. That was the case of, the case of William. The real case of William was that he wasn't even accepting having meals from his family because he was worried about them opening the door and him hurting them. So he wasn't refusing to even open the door and accept meals. So it was quite serious in his case. So in her case, it could be neglect. And it could be obviously dysfunction at work, disrupting her, not at work, at school, disrupting her schoolwork in quite a bad way. So what can we do for her? So she's obviously going to need some immediate support. And again, it's a case of calling the GP or local mental health services. There tends to be a way to call the local children mental health services. They operate a little bit separately. It might be severe enough if we're really worried that we might want to take her to A&E, just because she's a kid, and we want to safeguard her, and we're a little bit worried about stealing tablets, and we might need to sort of make a safe environment for her at home. And how to do that, we might need some immediate advice about how to do that. I mean, the case, why was she stealing tablets? If you want the answer, so this is a case of actually social anxiety. That was the presentation, and the tablets where the mom was taking some sedatives, and she was taking them to calm herself down. That was the thing. And you might see in cases of anxiety, people trying to take substances to calm themselves down. That's a very common comorbid presentation, right? So so yeah, that's another presentation of anxiety for you to sort of think about. In terms of heritability, again, what do you think is the most heritable out of all of these, perhaps? So heritable means that they run in families. Do you think anxiety disorders run in families or not? What are your thoughts? And if you had to choose one of these, which one do you think is the most likely to run in families? You just consider that for a second, and I'll give you the answer right away, which is this. Arachnophobia, so simple phobias, are the most heritable. Now, if you think about why do we get anxiety disorders, it's a combination of nurture and nature, right? So it's both. We look at the genetics. The genetics are actually sometimes quite hard. I think we know arachnophobia because it's easy. It's easy to track it down, and it's easy to sort of, see the diagnosis is present or not, and it's easy to do that. Whereas with other conditions, it's harder to track it down and define it, and to have the long follow-up studies that will reveal it. But they're all heritable. They all have a genetic component. We know this. So there's a preparedness for them. And we also know that they can also be influenced by social factors, your experience. So there's a little bit of nurture there, or lack of nurture there as well. So it's a combination. So sometimes you might think, is it genetic, or is it because we've observed our parents being fearful of a particular situation? That's called vicarious learning. So we learn the fear because our parents feared it and reacted in a particular way. And we know that this happens. For example, when you study anxiety disorders in adoptive children, they do adopt some of the attitudes of the parents in terms of, if the parent has a fear to something, it's likely that the child will develop it as well, even though they're not genetically related. So there is that modeling aspect of anxiety disorders, but it's not as powerful as people think, because a lot of people feel very guilty about, oh, I have this fear, I'm going to give it to my son or daughter. It's not as powerful as people think. In fact, if anything, is more the biological side that seems to be more powerful in general. So yeah, so they all have a heritability factor. The simple phobias seem to be the easiest one to track and the easiest one to evidence, but they all do. If you have one parent, it increases your risk. If you have two parents affected by anxiety disorders, it increases your risk a lot more. So having two seems to be particularly risky in terms of developing these conditions. When I say comorbidities, is what is the most likely thing that presents with these conditions? What is the most common other diagnosis that may come with it? And I've got a few possibilities here. So eating disorders, substance misuse, dementia, schizophrenia. Which ones do present with anxiety, which ones do not, just for you to sort of briefly think about before I tell you a little bit about it. So the most common, obviously, that I think it was very clear when I asked you the question at the beginning of what are the characteristics, what are the most common characteristics of anxiety disorders. Some people said depression, some people said like hopelessness, and that sort of thing. And the reason for that is because it is very, very commonly presenting together. So that's why you said depression. You said you talked about some of the symptoms of depression because they are very, very like to present together. But the truth is that all of these in this slide, they present together with anxiety. So in schizophrenia, you tend to get fears, and those fears can come with quite powerful anxiety. Substance misuse, the way that tends to present tends to be you have an anxiety condition first, and then later on you develop a substance misuse because you're using the substances to manage your anxiety condition, right? In dementia, it's more that the confusion that might happen in dementia makes you fearful because you don't know where you are or what's happening, and that triggers that anxiety. That's the way it seems to develop. In bulimia is more about, it could come with social phobia and would come with other anxieties. And in autism is actually, again, is this unpredictability and likely emotional dysregulation that seems to also present very frequently with symptoms of anxiety. So that's, I suppose the takeaway message is that it doesn't need to happen on its own, and it frequently happens in the context of other conditions as well as on its own. Yeah, I think that tells you something about that very, very high frequency that we explored in the early slides. That you were right on the money about that 35%. And finally, we're just going to visit very briefly how do you manage these conditions. Yeah. So what is the thing that works the best? So I've got a list of all the things that could be done here. So just to go to the actual answer, the thing that seems to work the best, particularly mild to moderate, is cognitive behavioral therapy, CBT, abbreviated in this slide. So CBT is a psychological treatment technique that consists on looking at what these worrying thoughts may happen, the fearful thoughts, what are they, and trying to sort of see if they're valid or not, helpful or not, and try to sort of see if we can modify them, right? Through practice, mainly. It's like gaining a skill. So that is part of it. The behavioral component of it in terms of anxiety tends to be about modifying that avoidance component. So avoidance is very frequent in anxiety disorders. And what we want to do to manage anxiety disorders is to increase that exposure. So stop that avoidance. in a planned way. It doesn't, it's not about you going and flooding yourself with the thing that you are most fearful of, but it's about a planning and a gradual exposure to the thing that you're scared, or the situation that you're fearful of. For example, in the case of agoraphobia, might be going in public spaces and taking that one step at a time. Sometimes it's about imagining yourself first being in a busy space, and then actually going there at a quiet time, and then actually going there at a busier time. And then you use, for example, relaxation techniques to cope with that experience and to desensitize yourself to that experience. So for PTSD, you may have heard of something called EMDR. EMDR is eye movement reprocessing and desensitization. The exposure there is more about the memories, the traumatic memories, and it's about using them and reprocessing them. But if you look at the whole project, or the whole program of treatment, is very similar. It has very many similarities with CBT in terms of that exposure plus training, plus looking at the thoughts that come with it, plus managing those thoughts and seeing whether they're helpful or unhelpful, valid or invalid, and whether they can be made more accurate and more helpful through a process of training. Then we've got many potential medications that can be helpful. I'll tell you that the technologies that we have for the treatment of anxiety are not very good in terms of the medication that we have. CBT and computerized CBT and even virtual reality-based CBT are all probably more effective. But we sometimes need to use some medication. The ones that can be helpful out of all of those, there's some versions of antiepileptics that can be helpful. And they are used and they are prescribed for that. But the ones that most successful are antidepressants, in particular the selective serotonin reuptake inhibitors, and they can be used alone, and they can be used in combination with the psychological therapies. In fact, they're more effective when used in combination with the psychological therapies. This is more for the moderate, more severe end of the spectrum. And we also have applied relaxation, which is a psychological intervention, which is about learning how to relax yourself progressively. It's another skill that you gain, and that can also be very effective. In fact, it's one of the nice recommended treatments. It is a training version of deep muscle relaxation. It's a particular relaxation technique that you can learn, and then you can deploy. And actually, when you finish the training for applied relaxation, you can bring about the relaxation response very, very quickly, within about a minute or less in any environment. So it's quite a helpful skill to have when you have anxiety, when you have an anxiety condition. And I have to mention exercise, of course. Exercise is a very powerful way of treating anxiety. Somebody mentioned the word stress when we were talking about the common factors in anxiety. Very common in anxiety, we get the stress response. So the physical symptoms of anxiety are part of that stress response. And the stress response is preparing us to do exercise. And we know that by actually doing exercise, when we have those, with that stress response, improves our outcomes overall. It contributes to diminishing the anxiety, for sure, as a treatment, but also it diminishes the impact, the physical health impact of stress long term. Because we know stress can increase the risk of things like obesity, heart disease, and other conditions, right? So we know that exercise minimizes these risks and actually treats the anxiety itself. It also has the advantage of treating depression itself, exercise. So exercise is very good, and it can be done, it should be done in combination with the psychological interventions, applied relaxation, cognitive behavioral therapy, and plus or minus medication, such as I said, the most successful ones tend to be those serotonin, selective serotonin reuptake inhibitors, those antidepressants that are actually very successful in anxiety. Benzodiazepines are not recommended because they are addictive and they can create problems. And the other medications that I've got there are also, they might be suggested, but they're not very effective, and they can have they can be counterproductive. Under special supervision, they might be recommended. So A lot of those techniques that I talked about, we have included in the Thrive app. For example, applied relaxation and also cognitive behavioral therapy. So, and obviously we have, our therapists or on the app that can actually, if you're presented with a problem with anxiety, can actually get in touch with you, enroll you in therapy, and work with you towards managing that condition better, and training you using those techniques that I talked about to diminish their symptoms. So I hope that was a helpful overview, a wide-ranging overview. So we learned about the frequency of these conditions. We've learned about how they present, the fact that there's many different ones. They can present at different ages. The fact that there's differences between men and women, and the fact that they, in general, and the fact that they have some nurture and nature factors, and how to go about treating them. Also important for you to retain that distress. So symptoms: is there distress? Is there dysfunction? What should we do? Is there risk? And what should we do? Yeah. So symptoms, distress, dysfunction. Are there any risks? What should we do? Just for you to sort of bear in mind when you encounter a case like this. So thank you very much, everybody. I think I might, I'm thinking, so I might stop there. I don't think there's any specific questions. How do I deal? I've got one question here. How do I deal with anxiety in a child? My youngest is 7. Her son got a fear of going to sleep in her room. Says that the worry is if the fire alarm goes off and we don't get her out. Yeah, so I think there's a lot of patience that has to be employed here, and it might be something that you, by repeated reassurance and support, it may extinguish itself. I wouldn't dismiss it. I would just be supportive. And if you have to explain this many times and ask her why she's worried or what might happen, and how you would do it, might help just to address the fear directly. But if she continues to have it, any particular, just remember that distress, that dysfunction, are there any risks? Is it going to interfere with her? Is her sleep going to interfere with other things? Then it might be worth seeking some advice, because again, 7 years old is the age where some anxiety disorders may start. So there we go. Okay. I hope that was useful. Thank you all very much, and I'll see you on another one very soon.